everyone. My name is Alicia Phillips, and I am the Portsmouth Campus Student Center Associate Director for Tidewater Community College. I am pleased to be here with you today on this Sunday afternoon for a feature on health equity and the African American community. This event aligns with the National Black History Month theme, the Black family, representation, identity, and diversity. To get us started, I will introduce you to our host and moderator, Terrance Afer-Anderson. He will introduce you to our distinguished guests, leaders, and activists in the healthcare industry. Terrance Afer-Anderson is the president and chief executive officer of TerraVision Entertainment Network. In August of 2019, he completed a fellowship in the Robert Wood Johnson Foundation's Culture of Health Leaders program. His culminating strategic initiative was the production of The Black Walnut, a feature-length film painting a compelling portrait of the African-American prostate cancer disparity. Mr. Afer-Anderson is a seasoned writer, producer, and director of stage, television, and film projects. Having staged more than 50 productions for the stage and screen and authoring more than 20 plays produced by Las Vegas, San Francisco, Washington, D.C., and extensively in Hampton Roads, Virginia. Most recently, he wrote, produced, and directed the stage play, the stage film Cast in History, featuring 9 obscure but quite remarkable notables from Norfolk, Virginia's African-American history. Wrote, produced, and filmed The Time Bank, highlighting the experience of 6 residents of local juvenile detention centers, and is writing, producing, and directing a documentary on the historic renovations of the Basilica of St. Mary of the Immaculate Conception, the oldest African-American Catholic basilica in the United States. Mr. Afer-Anderson also wrote, produced, and hosted the television program Health Watch for 16 years and wrote, produced, and hosted 22 editions of the community affairs talk show Biorhythms. He has produced television, theater projects exploring issues of diverse and social and criminal justice, African American history, teen pregnancy, prevention, spirituality, HIV/AIDS, drowning prevention, infant mortality, etc. He has also moderated panel discussions at the United States Capitol and the National Institutes of Health. Mr. Afer-Anderson is a recipient of numerous awards, to include the Distinguished Award in Television, Norfolk Public Library, PHEN Award, Prostate Health Education Network, NAACP Black Men Rock Image Award, Best Television Host, Exemplar Community Excellence Award, Hampton Roads Gazette Newspaper Foundation Award, Generic Theater Commitment to the Youth and Children Award in the Arts and Humanities, Continental Societies of Norfolk People's Choice Award, Best Documentary, Giving Angels Wings, chronicling the experience of father grieving for the loss of their infant children, Mid-Atlantic Black Film Festival, featured playwright, 25th anniversary Mid-Atlantic Association Writers Conference, Morgan State University, all the ALLI Award, the ALLI Award, Cultural Alliance of Greater Hampton Roads, Special Achievement Award, and Portfolio Magazine. Without further ado, Mr. Terrance Afer-Anderson.
Alicia, thank you for that extensive introduction. I expected something a little bit more abbreviated, but I do appreciate that. Thank you so very much. I also want to thank our distinguished panelists that are joining us today. This is a very special event that we're staging, the health inequities, health disparity. Those are critically important issues. And we are going to, I believe, enlighten people to a degree that they've not previously been enlightened on the incidence of health disparities and inequities impacting African-American people and other minorities. I wanted to, the reason that I decided to do this kind of work is related to, and I'm going to share my screen here, is related to some work that I was doing in the community and still do. And what that work is here we go. Okay. I, since 1998, I have done a lot of work with incarcerated populations, especially with incarcerated fathers. And it occurred to me that when men are incarcerated, they become invisible in their community. They're no longer active participants in their community. And it made me think of Beth Ellison's book, The Invisible Man. And here is a quote from the main character in that book, is a narrator who is really not defined by name. And that's Ellison's deference to the concept of African American men being invisible, that he did not name that character. And this particular quote, I think, is quite meaningful. When they approach me, they see only my surroundings. They only see themselves or figments of their imagination. Indeed, everything and anything except me. And the real contradiction, the real contrary thing to that is that when it comes to systemic injustices and systemic justice, rather, African American people, especially African American men, do in fact tend to be invisible. But when it comes to the impact of inequities that we face and injustices that we face, we do in fact really be, we are very visible because those things impact us disproportionately. And I will cite an example that I encountered recently. Um, because of COVID, of course, whenever I go out, I wear a mask. And recently, it's happened a couple of occasions now, because it's so cold outside, and I want to oblige and follow the CDC guidelines and federal guidelines about wearing a mask. I wear a fedora on my head to keep me warm. But I've learned on a couple of instances that if I go into a public place as an African American male wearing a fedora and a mask, I attract undue attention. I walked into a convenience store not very long ago, and I was 15 feet away from the door, and I walked past the counter. And after I gotten that far into the store, they hollered out, "Can I help you?" I paused for a moment. I started to say something to them, but I left it alone. So I wasn't invisible in that instance, of course, because it dealt directly with a real testimony about how someone becomes quite visible when they're an African American male, but when it comes to getting justice and equitable treatment, we do intend to become invisible. And I think that the onus on us as African American men is to make sure that when it comes to our health care, to our health, that we do not become invisible in our communities, because we are already facing challenges, and so we need to do things that are proactive in terms of our own health care, so that we do not become invisible in our families and invisible in our communities. Because again, as the work that I've done with incarcerated populations have shown me, that when men are not involved in their community, the community is in fact suffers, their children suffer. We always say that when someone is incarcerated, they are not the only ones that are locked up. Their children and their families and their communities are locked up away from them as well, because they are invisible. And when that comes to healthcare, that's particularly important. For African American men, being invisible comes with alarming liabilities and disparities. On the average, African American men have a lifespan of 7.1 years less than other racial groups. African American men have higher death rates than all leading causes of death. Black men die prematurely from cardiovascular disease at a rate twice that of white men. African American men are 5 times more likely to die of HIV/AIDS. And for my own personal journey, and I'm going to talk a little bit about that, a little bit more about that in just a second. I dealt with prostate gland. Now, the prostate gland is really truly only about the size of a walnut. It's a small thing. But if a man doesn't take care of himself and he leaves prostate cancer, and so he has prostate cancer and he goes undiagnosed, he can find himself up a tree, being a mortality, dying, and rendering himself invisible. And the compelling portrait of the African American prostate cancer disparity: Black men have the greatest risk of developing prostate cancer than any other racial group. Prostate cancer is the second leading cause of cancer death among African American men. African American men die from prostate cancer at more than 2 times the rate of white men. 31,500 plus men will die from prostate cancer this year, disproportionately impacting African American men. Black men in Virginia have the highest incidence of mortality rate in this area, in Hampton Roads rather, have the highest incidence of mortality rate in the state. Black men in Virginia are diagnosed at a rate of 1.97 times that of white men. Black men in Virginia die at a rate 2.4 times greater than white men. Metropolitan Hampton Roads, again, has the highest prostate cancer disparity in the state. Portsmouth's population is 52% non-Hispanic Black, and it has the highest mortality rate in the state. Now, that is a little bit of a contradictory information because Petersburg has Petersburg, Virginia, has that distinction now. At 49.6% African Americans are the majority of population in the city of Hampton, yet it has the second highest prostate cancer diagnosis rate in the state, 174.3 cases per 100,000 men. Now, my own personal journey, I was diagnosed in 2010. My PSA level was 6.7. My Gleason score was 7, which was equals 3 plus 4. If that had been 4 plus 3, my situation, my status probably would have been a bit higher. I had brachytherapy to be treated. Brachytherapy is the implementation of radioactive seeds. And since then, my PSA levels for the last few years has hovered right around 0.4, which is pretty good. And I'm going to ask one of our panelists more about the PSA levels. And this is why I started doing the work that I do in terms of prostate cancer awareness. When I was diagnosed, neither of my brothers had been screened for prostate cancer, neither one of them. My eldest brother was diagnosed at the same year that I was because both of them were screened when I was diagnosed. My elder brother was diagnosed at a later stage of prostate cancer than myself. I have always done work in theater to address social inequities, health inequities, and so forth. And these are some of the just flyers for some of the work that I've done. The fifth deals with incarcerated fathers. Casting History deals with how African Americans locally have circumnavigated the inequities that they've dealt with to become phenomenal people. The Phoenix and the Ashes deals with the 1926 abduction of an African-American, priest who worked at an African-American Catholic school who was abducted by a group called the Know Nothings. In the lower left-hand corner, this is Harlem and Nettie. That's a love story between two slaves that was staged in Las Vegas twice. Railings is one that specifically, of course, deals with HIV/AIDS. It's the story of a teen who runs away and encounters the spirit of a 19th century cowboy, African-American cowboy, who helps him deal with his illness. And The Tempest is a love story that takes place during Hurricane Katrina. And so I mentioned earlier that I have this film, The Black Walnut, and it's a film highlighting the African-American prostate cancer disparity. I developed it as part of Robert Wood Johnson Foundation Culture Health Leader Scholarship Program I was involved in. It was my culminating strategic initiative. It was shot and produced entirely in Hampton Roads. It features 9 prostate cancer survivors. I wanted to do something different. The main character, his story is fiction, but I supplanted that. The reason I made the main character a fictitious story is because I wanted to make sure that I involved a lot of the issues that people dealing with African-American men deal with prostate cancer. So I created a character that would provide me the platform to do that. But that character, that fictitious character, is supplanted by 9 actual prostate cancer survivors in acting roles and dramatic roles. The film premiered in Washington, D.C. as a part of the graduation, the Robert Wood Johnson Fellowship Culture Health Leaders Program in Minneapolis, Minnesota, staged by the A. Philip Randolph Institute in the Bay St. Louis, Mississippi. It was presented by the University of Alabama, Birmingham. And it was done through collaboration with a number of community partners. And the whole idea of that film is to recruit people as ambassadors to continue spreading the word. And it has proved very effective that way. What I want to do now is show you just a little bit of this is a trailer from the film.
Whatever happened to Isaac Royster? A successful defense attorney at the top of his game, catering to those of little means. He met and married Imani Richardson, a pediatric nurse and the love of his life.
When I laid eyes on you, I realized that magic lives between heartbeats. And my heart skipped a beat, creating a space that only you can reside. To new beginnings.
Life was perfect.
Oh my God! Isaac! You still amaze me, Isaac. How do you continue to peep into my dreams?
Yes, Isaac couldn't ask for more. He had done everything right. Summa cum laude undergraduate at an HBCU, top of his class at an Ivy League law school, partner in a prestigious law firm. He was covering all of the bases.
Yeah, baby.
Thank you.
I love you.
So he thought.
I'm sorry, baby. It must be the stress from this new court case that I have.
Honey, stress can cause a host of illnesses. I mean, Isaac, you've had some other things going on for a while now. You need to see Dr. Brett. I won't take any more excuses.
Okay. Okay, I promise. Because I know if I don't, you're going to take me to court behind this.
Your subpoena is over there in that nightstand.
Okay. Imani, I didn't know. I should have paid more attention. Hey guys, come here. Look, Daddy loves you more than all the stars in the sky. But you know, sometimes grown-ups make mistakes that they can't recover from. But I want you to know that you and your mommy, you're the best things that's happened to me in this world. And I love you.
I love you too, Daddy.
There is a health scourge disproportionately impacting black men in America. But Isaac listened. He listened to Imani, and eventually he did what he was supposed to do. That was not the case, however, with his brother Irving, also an attorney, yet one who wasn't judicious about his own health. He is the one being buried here today. There is a small gland in men only about the size of a walnut. It is the prostate. If cancerous and left untreated, it can take down mountains. African American men are at the greatest risk. Isaac Royster's story is just beginning. This is a tale of the Black Walnut, coming soon.
what I'd like to do now is introduce my distinguished panelists, and I'm hoping that we do not have any further technical difficulties. Those of you that are late joining us, I understand that there was an issue with YouTube, and so you're being transferred to us now. So thank you for joining us, and I'm delighted that you have joined us. And again, I'm going to introduce our panelists. And panelists, when I call your name, if you could just acknowledge yourself with a wave on the screen or something, so folks have some idea who it is that I'm talking about. I want to begin with Natalie Burke. Natalie is a nationally known speaker, equity evangelist, strategist, writer, master facilitator, and public health leader. She is the president and CEO of CommonHealth Action, whose mission is to develop people and organizations to produce health through equitable policies, programs, and practices. A graduate of the University of Maryland with a degree in government and politics, Ms. Burke has been selected for numerous fellowships, including the Emerging Leaders in Public Health Fellowship, hosted by the University of North Carolina School of Business and Public Health, New York University's Robert F. Wagner School of Public Service Lead the Way Fellowship for visionary and entrepreneurial leaders in the nonprofit sector. And she has also served as a W.K. Culler Foundation Fellow, conducting federal health policy analysis at the National Health Policy Forum in Washington, D.C. In 2012, she was elected to serve on the Council of Innovation Advisors for Converge Us, a national initiative focused on technology and social innovation. Since 2015, Natalie has served as the co-director of the Culture of Health Leaders National Program Center, funded by the Robert Wood Johnson Foundation. She directed the Kaiser Permanente Institute for Equitable Leadership in Baltimore, and she is a member of the Institute for Healthcare Improvements Equity Advisory Group. Natalie, again, thank you so very much for joining us. All of these people, they have such incredible and extensive credentials. If I were to read all of them, all of the accomplishments, we'd be here for quite a while. So we're doing an abbreviated version. Next up is Mr. Mekbib Gemeda. Mekbib, if you could just wave and acknowledge yourself to our participants. Mr. Gemeda serves as a vice president of diversity and inclusion at Eastern Virginia Medical School, leading efforts to advance health equity and diversity and inclusion. Prior to joining EVMS, Mekbib served as the assistant dean for diversity affairs and community health, and founding director of the Center for the Health of the African American Diaspora at the New York University School of Medicine. Mekbib's efforts to advance equity nationally include serving on the steering committee of the Group on Diversity and Inclusion of the Association of American Medical Colleges. He is the inaugural chair of the Health Professions Chapter of the National Association of Diversity Officers in Higher Education. He also serves on the state board of the Virginia Center for Inclusive Communities and as a treasurer on the Board of Commissioners of the Norfolk Airport Authority. Thank you again, Mekbib, for joining us. Next up is Dr. Angela Mercer. A retired physician, Dr. Mercer spent many years serving as a medical director of the Norfolk Community Health Center, a nonprofit health center specializing in adult medical disorders. Prior to the creation of that nonprofit entity, Dr. Mercer was in private practice, having offices in Norfolk and Suffolk, Virginia, where she practiced internal medicine for over 30 years. She is also an assistant professor of clinical medicine at the Eastern Virginia Medical School and is a member of the community faculty at the school, mentoring and teaching medical students. Dr. Mercer completed her undergraduate work at Swarthmore College and received her doctorate of medicine from the Medical College of Virginia. She completed her medical training at Harlem Hospital and the Sloan Kettering Memorial Cancer Center. Dr. Mercer has also served on the Governor's Advisory Board for Emergency Medical Services and on the Board of Directors for the Edmark Hospice for Children. Currently, she serves on the Board of Directors for the United Way of Southampton Roads and is Vice President of the Greater Norfolk Medical Society of Southampton Roads, a local component of the National Medical Association. Dr. Mercer is also a co-founder of the Cooper Mercer Institute, a nonprofit organization that sponsors informative and interactive events such as the annual FET, Promoting Healthy Active Teens Conference. Again, Angela, thank you so very much for joining us. Next up, and our last panelist is Dr. Mark T. Fleming. Dr. Fleming is a board certified in medical oncologist. He received his BA at the University of Pennsylvania and his doctorate in medicine at the Medical University of Ohio. Dr. Fleming completed his residency at Temple University Hospital and his medical oncology fellowship at Memorial Sloan Kettering Cancer Center. He joined Virginia Oncology Associates in August 2006. His special clinical interests and expertise are in cancers of the bladder, kidney, prostate, and testicles, as well as phase 1 novel drug development. He is heavily involved in cancer research as a principal investigator for clinical trials, locally and nationally, collaborating with institutions like Duke University Network, Huser Oncology Group, the Prostate Cancer Clinical Trials Consortium, and U.S. Oncology Research. Their purpose is to provide the latest treatment options to patients. Dr. Fleming is a co-author of 2 recent articles leading to new drugs approved for cancer patients. The first was published in the New England Journal of Medicine. It was on increased survival with enzalutamide in prostate cancer after chemotherapy. The other regarding the groundbreaking article regarding the groundbreaking use of immunotherapy in bladder cancer was published in The Lancet. A past president of Virginia Oncology Associates, Dr. Fleming currently serves as the medical director of U.S. Oncology's Genitourinary Research Committee, studying bladder, kidney, prostate, and testicular cancers. He also previously served as both the division chief of the Eastern Virginia Medical School, Department of Hematology and Oncology, and as president of the medical staff at Centura Careplex Hospital. As a co-founding member and past president of the Hampton Prostate Health Forum, Dr. Fleming is a passionate speaker on the importance of cancer education and the early detection of prostate cancers. Again, Dr. Fleming, Mark, if you would please acknowledge with a wave to the group. And guys, again, thank you all to the panelists for joining us today. You all are very special people to me. I count you amongst my friends and colleagues. And I wanted each of you to speak today because of the important knowledge, the great depth of knowledge that you have when it comes to health, equity, diversity, and inclusion. And what I'd like for you each to do now is to do a presentation that we're scheduled on this topic. Natalie, let's begin with you, please. If you could unmute yourself.
I'm coming. I'm going to go to screen share.
Right.
So good afternoon, everyone. If Terrance asks me to do something, I'm going to do it. So I'm happy to be here with you. And what I'm going to do is hopefully do some foundational level setting in terms of establishing some common language and some common understanding for the rest of the discussion that we will have. I'm going to move quickly. Some of you may be familiar with this, and that's great, but we may also have some folks who are less familiar. One of the things that I do in my work is to orchestrate constructive discomfort. This is this idea that in order for us to achieve any type of meaningful change in society, whether that's in our personal lives, whether that's in society at large, it requires us to get uncomfortable and to recognize that to sit in that discomfort is necessary before we see something different emerge in the world. So having these conversations about equity can be somewhat uncomfortable because we have to talk about a number of different things. First, though, I want to make sure that we start with defining health equity. I really like this definition offered by Dr. Kamara Jones. And so many of you may be familiar with her work with regard to health inequities and health equity. But this idea that health equity is about assuring conditions where all people can get to their optimal health is critical. Because your health is not an accident, it's a production of society. It's about 10 to 20% genetic, 30 to 40% based on your personal behavioral choices. Do you eat right, diet, exercise, engage in risky behavior, wear a seatbelt, wear a condom, wash your hands, get preventive care. And then the other 40 to 50% is really based on systems and institutions that create the context and the construct within which you live your life and make your decision. So things like housing, education, transportation, employment, structural racism, all create the conditions within which we live our lives and make our decisions. And so that's a little bit about how health is actually produced, which is a really important part of this conversation. Another piece with regard to the language before I get into anything else that I wanted to cover is really the difference between disparity and inequity. And so this is, I think, for many people emerging. We have talked about health disparity for many years, when in fact, we should really have been talking about health inequity, and here's why. A health disparity is merely a difference in status or outcome between groups of people. It's merely a difference. And so a difference in and of itself is not necessarily a bad thing from a societal standpoint. Some of these things are naturally occurring, right? A health inequity is a specific type of disparity. It's a disparity that's the result of things that are preventable, avoidable, and unjust. Health inequities are really about decisions that we make with regard to policies and practices that create barriers to people having the opportunity to be healthy. So the example that I like to use with regard to health disparity versus health inequity, if you were to look at the occurrence of breast cancer in females and males, you will find that females have much higher rates of breast cancer. That is a naturally occurring thing. That is a health disparity. But if you were to look at survival rates with regard to breast cancer for females of different races, you will find that African American women are less likely to survive. Now, while there may be some portion of that that has to do with genetic predisposition, there's more of it that really has to do with things like access to care, culturally competent care, and the way that we have structured policy and access around health insurance and health care that serve as barriers and then lead to higher rates of death, right? So that's what really makes that a health inequity. So here's the thing, there are no accidents. Health inequities being produced are really a manifestation in many ways of social identity, policy, history, and power, right? So social identities are how we are grouped, how we're grouped by shared characteristics. We don't necessarily sign up for these groups, but we are considered members of these groups. And there are really three components to this. One, social categorization. And this is how we organize ourselves into groups so that we can understand the world and how it is that we should be in relationship to one another. Then there's social identification. Once we're in our group, there are norms and characteristics that we share, right? And ways that we experience the world that are very similar. Once we're in our groups, we engage in what they talk about as social comparison. So my group compared to your group, the in group versus the out group. And we see this happen throughout society. This is why some people experience privilege and others experience oppression. And really what that is a manifestation of how we value people in this society based on their identities or how we choose to devalue them. In America, what we've done historically for 400 plus years is to really devalue Black identity and to engage in anti-Black racism. And when coupled with power, power being the ability to define reality for yourself and for others, we have seen this manifest in public policy for the past 400 plus years that took us from American slavery to segregation to the post-segregation period. You'll find then, of course, that we had redlining and we had periods of mass incarceration. What do all of these periods of time have in common? Public policy based on social identity, rooted in anti-Blackness that has to do with devaluing Black identity. This is why social identity is critical to understanding how health inequities happen. There's pain associated with racial identity, and that's really important to note. And in fact, how that is played out is crystal clear and really in front of us. So here's an example, power being the ability to define reality for ourselves and for others, of how this shows up in something as simple as a nursing textbook. So this comes from a textbook from 2017 called Nursing, a Concept-Based Approach to Learning. It's in a chapter that's about acute and chronic pain. And in this chapter, take a moment and look at the bullet points here because they're really important. And think about it. This is a book that was being used to train nurses. It was out and being used, right? Not up for review, but in the classroom being used. So if a nurse was to look at this and to believe these characterizations, and I'm going to ask you to look at the second bullet point, Blacks often report higher pain intensity than other cultures. With that in mind, would that nurse automatically believe when a Black person is asked to rate their pain on a scale from 0 to 10, would they believe it or would they actually question it? Well, one of the things that we know is that when it comes to treating pain, there are significant inequities that African Americans experience within the healthcare system. And in fact, even down to pediatricians, they find that pediatricians will undertreat the pain of a Black baby compared to the pain of a white baby. Now, I have to wake up and operate in the world every single day. I would like to believe that that is not intentional, but in fact, it is the result of implicit or unconscious bias. But this is important because it's not about people's intentions, it's about the impact, and it's about how are people experiencing healthcare within the context of their identities, right? And then how does that then factor into the inequities that we see? Well, when we do want to talk about that and how do people experience things differently, we have to think about how people are experiencing COVID-19 differently. And whether you're talking about Black, Latino, or Indigenous populations, we know that rates are much higher, and we know that illness and deaths are much higher for these populations. Some of this, of course, has to do with the types of professions people are in, the living conditions that they experience, but also the fact that for many of these populations, they were medically vulnerable prior to the virus. So the presence of chronic disease has factored into how people have experienced COVID and actually their outcomes. And with that, now what we have found was that in the first 6 months of 2020, that there are significant inequities with regard to changes in life expectancy. And in fact, Black males have lost 3 years of life in the first 6 months in terms of life expectancy. And that is huge. Think about it. In addition to that, we are seeing inequities with regard to access to vaccines. In fact, I had a conversation with my father this morning, who is desperately, as a prostate cancer survivor in Fulton County, Georgia, trying to get access to a vaccine and can't seem to be able to do that. Why is this important? Think of it like this. If we look at life expectancy dropping for Black people overall, and if you look at this chart where you see Black, that it says now life expectancy dropped for Black people from 74.7 down to 72. But the way that we have formed like local policy actually said in many jurisdictions, the way that they prioritized people for vaccine access was 75 and older. But Black people are, in terms of life expectancy, only expected to live until 74.7, but can't access it until they're 75. And in fact, even if you were to drop that down to 65, as some jurisdictions did, think about how many African Americans are already at the point of possibly dying at that stage in life, right? Public policy needs to be set with these types of differences and these types of inequities in mind. So to move from health inequities to health equity, well, what it really requires us to do is to provide all people with fair opportunities to achieve their best possible health. So when I say this, people say, well, fair, they ask the question over and over, what's fair? Here's the thing, fair is not what you think it is, and fair is not what I think it is. Fair is whatever is necessary to get a person, a family, a community, or a population to their best possible outcome. That means that when we're setting health policy, things like access to vaccination, we need to set that policy in a way that ensures that people have the opportunity to get to that optimal health and to get to that best possible outcome. I'm going to stop there and I will stop sharing my screen. And Terrance, do you want to do questions now or after?
I think what I'm going to do in the interest of time, because of the technical snafus that we had earlier, what I would do is we'll just go on to the next panelists. And then we'll have some panel discussion afterwards. And some of the questions that I will ask will impact everyone else as well. Mr. Gemeda, if you would go next, please. You prepared to go next?
Yes, I will go next. Thank you so much. This was a wonderful presentation already so far. And I think, Natalie, you have really placed me in a nice place to move on. I'm not sharing anything, but I'm going to be very brief, and I will look at one aspect of this inequities and equities in relation to the educational workforce kind of context, because that is the space that I generally live in academic medicine. So it said that the first African American to practice medicine in the United States was James Durham, and that was in 1788. and he was known to be an expert, particularly in diphtheria, and he was practicing in New Orleans and was invited to come back to Philadelphia, where he was from, by Benjamin Rush, who was the most significant physician of the time and one of the signers of the Declaration of Independence. And the first African American to actually get training in medicine was James McCune Smith, who graduated from the University of Glasgow in Scotland because he was unable to pursue training here in the United States, and came back in 1837, started his practice in New York, and was also the first African American to get published in U.S. medical journals of the time. And now it is very interesting to see that 200 years after that, we in between we have had great achievers and who have pioneered various things, like Charles Drew, who created the blood bank and everything. We still are at 5% physicians in the United States who identify as African American. And so when we look at the number of physicians that are in practice, we have about 5% African American, about 5 or 6% Hispanic, much less American Indian, and that has definitely an impact in the kind of care that is produced for the African American population. And so when we see the students, for example, in terms of like who cares for whom, we have seen studies where a majority of African and Black African American students and other minority students are actually more interested in going back and serving underserved populations. And the same when we have seen studies as well, which show that when we have diversity in the educational environment, the other students who come from other identities are more likely to be interested in serving more diverse populations as well. So that has a great impact in terms of like who goes what and serves individuals that need the care that we need to provide in order to reach that equity that Dr. Burke was talking about. And so when we see in the landscape itself, and we talk, people that are in practice like Dr. Mercer, we know for a fact that actually the landscape shows that the people that are serving the largest number of populations that are marginalized are actually coming from those people that are underrepresented in medicine. And what do we see when we go into actually understanding what this translates into? And the study shows us that that physicians who come from these identities are likely to choose primary care specialties, which are most important in the forefront to serve patients of their own ethnic groups, serve Medicaid recipients more, and work in health and manpower shortage areas. So that has an impact on how we can actually achieve equity. And when we go to studies that show a strong rationale for increasing diversity, we can also see how the patients are actually receiving care. They are more likely to talk with Black doctors about their health problems. Black doctors are more likely to write additional notes about their subjects when they're writing their medical notes. Cardiovascular disease impact significantly led to a 20% reduction in gaps in areas where there are, a diverse workforce, and cholesterol screening and invasive testing were up by 20%. Flu shots as well were significantly more likely when we have diverse caregivers and workforce that are working with patients that are diverse and come from different identities. And what this tells us is we do have an opportunity and a challenge in terms of looking at how we address this problem, also from the perspective of the workforce development, which brings us to the vaccine issue that we are facing today, and the issue of trust that is associated with the healthcare system. It is much related to also the inclusion of African Americans in the healthcare workforce that has become a barrier that we haven't been able to address in critical ways for a long time. So I'll stop there and look forward to the conversation.
Thank you, Mekbib. Dr. Mercer, if you would go next, please. Unmute yourself.
Hello, thank you for having me. I just feel quite privileged to be included in this panel of distinguished speakers. I am not sharing as well, and I just wanted to, and I too will be brief. Health and equity within the Black community is not a new concept. Inequities of all aspects of daily life have existed in this country since the first African set his foot on this soil before 1619. Enslaved Africans, needless to say, suffered life-threatening and life-ending consequences from these inequities that were engraved into the American society for centuries. Following emancipation and Reconstruction, African American patients and doctors were faced with all kinds of hurdles that encumbered the delivery of health care, good or subpar, to the Black community. In 1895, Black physicians came together to develop an organization that would eventually serve as the collective voice of African American physicians and the patients that they serve. That organization is called NMA, or the National Medical Association. This was during a time in America when Jim Crow laws dominated all aspects of daily life. Under this backdrop of racial exclusivity, memberships in America's professional organizations, including the American Medical Association, were restricted to whites only. The organization that I represent today is the local component of the NMA. That's the organization that we developed in I wasn't here, but in 1895, that continues to serve as a collective voice for the underserved African American. Let's look at some numbers. We're going to fast forward to the 2000s. And Mr. Anderson, and I'm sure Dr. Fleming will talk about different numbers related to inequities in cancer, specifically prostate cancer. But inequities affect many health states. For example, African American ages 18 to 49 are 2 times as likely to die from heart disease than whites. African Americans ages 35 to 64 are 50% more likely to have high blood pressure than whites. African American adults are 60% more likely than non-Hispanic whites adults to be diagnosed with diabetes, and that was in 2016. In 2017, African Americans were 2 times as likely to die from diabetes as compared to non-Hispanic whites. And now in 2020, African Americans were almost 3 times more likely to be hospitalized for coronavirus than white people, and almost 2 times more likely to die from COVID. So we say, why is this? Why do these numbers look like this? And I have to say that Dr. Natalie Burke's discussion really just hit the nail on the head. And I'm just going to add a few pointers there, my points. I feel that the cause of these health inequities is multifactorial and can include lack of access to care, lack of trust in the healthcare provider when you do access the care, lack of knowledge and understanding as it relates to health issues and disease states, lack of knowledge as it relates to living healthy lifestyles, lack of access to all that is needed to implement change necessary to live healthy lifestyles, such as living in food deserts, costly gym memberships, and living in areas that have easy access to fast foods. All of these, like Dr. Burke has said, reflects one's socioeconomic status. And also there's a lack of patient advocacy. So I'm representing the Greater Norfolk Medical Society of Southampton Roads, and I asked, what are we doing to address these needs? Our mission statement is to serve as an informed voice for those physicians who care for African American patients. Our goal is to serve the community through education, advocacy, and activities targeted at reducing and eliminating the healthcare disparity between minority and non-minority populations. So over the years, we have participated with and without partners in various health screens, informative workshops, and health forums. We have partnered with organizations such as the Norfolk Public Health Department. Mr. Anderson was there. Illuminating a Good Health Coalition under Mr. Anderson as well. Mercer Institute, Norfolk Community Health Center, and Eastern Virginia Medical School, Department of Diversity and Inclusion with Mr. Gemeda. We also provide scholarships to African American medical students. Most recently, we have co-partnered with another nonprofit organization called Hampton Roads Medical Scholars Institute. And this group is comprised of African American male doctors that are mentoring African American high school male students who are interested in becoming physicians. Thus, we are attempting to increase the pipeline for more African American males in medicine as medical providers. And Mr. Gemeda spoke on that and the importance of us having, of the patients having physicians that look like them. We also are developing a health literacy program, which will be a year-long program that will include workshops, lectures, screens, all centered around various important disease states, thus working to bridge the healthcare disparities or the negative healthcare disparities gap that currently exists. The focus is empowerment through knowledge. Lastly, I'd like to just state that we did co-produce the film, The Black Walnut, with Mr. Terrance Afer-Anderson. Thank you.
Thank you, my dear. I appreciate that. I will also share for those of you that didn't know this before, Dr. Mercer and I graduated from high school together. This was just last year, right?
Right.
Okay. Dr. Fleming, sir, if you could bring us all home, and then we'll have some panel discussion here. You're muted, Dr. Fleming.
Can you hear me now?
Yes, sir.
I'll be brief. Let me commend my co-presenters, the panel. They were outstanding, laying out the background in terms of health disparities that exist. I think that I sit before you as a part of a private organization that I work with 39 other physicians, and I think that healthcare has changed dramatically. My father is a physician. He was an internal medicine physician like Dr. Mercer. And when my father finished in medical school in 1962, his real only options was to join, to really create a medical practice. And historically, when you look at Black physicians, they were ones who set up shop in our communities and practice care, basically because of a segregated society and also a segregated medical culture. I think that is very different in 2021. A new graduate from EVMS would now be looking at what healthcare organization I'm going to join. So it's a lot different now, and I think that makes it very difficult for patients to navigate the process. So I want to be here just as one who works with a group and with an organization. When we were confronted with just the disparities, it's harder to convey that health disparities exist within your own patients, because your colleagues think that they're providing the same level of care no matter who's before them. I'll let the panelists move on, but I love Dr. Burke's when she mentioned the fact that whatever is necessary, and I think that's important for organizations to try to implement kind of changes on the local level to try to address these issues. And I think having a diverse workforce, I think, is absolutely key. People coming from broad backgrounds and an inclusive environment. I'll end there, and I'll let Mr. Afer-Anderson move forward.
Well, thank you for calling me Dr. Afer-Anderson. I have a dear friend that does that on occasion. Guys, again, thank you so very much for your great contribution to this discussion. And at this point, we will start our panel discussion. And if any of you that are watching have questions, do please put them in the chat. And Alicia, if you could help me monitor that chat, and so we can make sure that we address all of those things. But I have some specific questions for folks. And at any time when I ask a question, panelists, if you feel compelled that you want to respond as well, do please let me know. And I will do my very best to make any of the questions. If I have questions unique to any of you, well, I'm going to try and limit it at this point to just one question because of the interest of time. I will share that my colleagues in the theater many years ago, they used to call me a creative genius, but a technical weenie. And that came to light today. I think that the problem with the video was that I clicked on it too many times. Natalie, Ms. Burke, I just made a reference to theater. One thing that I've learned in theater is that an audience assumes a personality, and that personality can differ in terms of their reactions and their behavior and the way they receive things from one night in performance to another. And when you travel around the nation and you're speaking on issues of health equity, diversity, and inclusion, do you notice a difference in the way audiences respond, let's say based on locale, based on the ethnicity of the audience? And do you just see how the people tend to respond differently based on their own orientation? And second part of that question would be, how do African-American audiences respond to your sharing information on health disparities and so forth?
So thanks for the question, Terrance. What I would say is that I have found audiences that are primarily people of color tend to understand this idea that your health is a production of society, and that it's about more than access to care. It's about more than health insurance and culturally competent care. They tend to understand social determinants of health, which from a public health perspective, we know creates that context for your life and whether or not you have the opportunity to be healthy, because they see how inequities in housing, inequities in education, inequities in income all factor into whether or not people have the opportunity to be healthy. Audiences that are predominantly white have the tendency to look more towards individual health behaviors and health choices and say, this is about what you've decided to do, and that's why you are unhealthy or unwell. And so that's where I see that there's a significant difference. I think over time, what I've learned is about how to make the case to those audiences that are resistant to this idea that health inequities are not about flawed genetics, which is one part, or bad behaviors, which is the other part that you will often find in those audiences. And sometimes that's through pointing to some things that exist within their own families and giving them examples to which they can relate and say, oh, well, that's not because of that person doing something that is quote unquote wrong with regard to health behaviors. So I think there's a way to deliver the message, and we have to continue to deliver that message if we want to address the policies that shape and frame those social determinants of health.
You made a reference to cultural competency, and this is a question that I'd like to put out there for all of the panelists, and your thoughts on cultural competency. And I'd like to begin, Natalie, if you would define cultural competency. And Dr. Fleming, you made a reference to how physicians see patients, different patients. So I would be very interested in your thoughts on this area of cultural competency as well. And I see that Dr. Shabazz is with us, Dr. Laura Shabazz, who appears in the Black Walnut film. And Dr. Shabazz, if you want to contribute anything by chatting on that topic, as well as Dr. Mercer and Mekbib. So let's begin, Natalie, with your definition of cultural competency.
So cultural competency is really about an awareness and understanding of cultures, our own and those of other people. And it really means that you have to be willing to engage in a continuous learning journey, understanding that culture also shifts and changes over time. And then accessing that knowledge, that awareness, and that information in the way that you engage with people so that you actually value their culture, not just tolerate their culture, not ignore their culture, but rather that you actually value it in the process of engaging with them. Here's the thing though, I think in many ways in healthcare, we got stuck on diversity, inclusion, and cultural competence. I look at those as the tools that we decided to help us build a bridge from where we were to where we hope to be. But the reality is we've built a bridge to nowhere. We're not where we were, let's say back in 1954, back with Brown versus Board of Education. We're certainly not there, but we absolutely are not where we need to be because equity throughout society and equity in health and in healthcare don't exist right now. And so the question then becomes, if diversity and inclusion and diversity, inclusion, and cultural competence are not enough, what do we need to do? We have to deal with these issues around power, this ability to define reality for ourselves and others, and how that factors into the policies and practices that create those conditions and the experiences that people have as they engage in all systems, including the healthcare system. So cultural competence is not enough. People can be very culturally competent and engage in behaviors and practices every single day that lead to inequities.
Would either of you like to add to that? Thank you, Natalie. Would either of you like to add to that?
No, can you hear me?
Yes.
Yeah, Dr. Burke is spot on. You know, this is what she does, and so she's an expert in the field. You know, as an organization of over 500 employees, given the events of 2020, we understood that we have to address unconscious bias. Probably my proudest achievement as being past president of my group was that we created an inclusion council. We created an inclusion council across our organization made up of physicians, made up of nurses, made up of staff to address these issues. And there's three components to that. One is looking at the patient experience, because addressing some of the points that Dr. Burke made is that you have to look at from how patients perceive things. So we have a group that's addressing that. Then employees have their own experience in terms of how they deal with the institutional issues that exist. And 2020 was quite traumatic in terms of the racial trauma. So we have three kind of committees looking at those issues. And so as an organization, that's how we try to set out and do that, because it's taking the health policy issues that Dr. Mercer, Dr. Burke, and Dr. Gemeda are addressing and trying to put it in a private organization. Our board, we don't have an outside board telling us what to do. We had to have some tough conversations in terms of addressing those issues. And I can share with you, those are not easy issues when you have to confront, are there in fact institutional issues going on within a private practice. So Dr. Burke, we should just listen to her. She's laying out the issues, what exists. She knows it very well from that perspective.
I'd like to just say one thing, and I want to Mr. Gemeda to comment on this. So EVMS now has a term for their students, and I really think it has to start too with how physicians are trained in medical school. But the term is cultural humility, which I think is just a wonderful term, and it just supersedes cultural competence. Because if you have a human to a human and you're humbled, and humility, you're humbled by the experiences of that person in front of you. It's a whole presentation, and if you try to get into what their particular culture does. But Mr. Gemeda, could you just speak to that just a minute? You
yes,
unmute yourself.
Unmute yourself.
Yes, I did. Sorry. That touches on what Natalie described earlier quite well, and really the concept is to look at the cultural connections that are formed within, like the communications that happen, whether it is between the healthcare professional and the patient, or the healthcare team. It understands the power dynamics, meaning, like that humility that is needed in order to be actually effective in care. And underlying that is really understanding, having structural competency, meaning, like that we understand that the issues of equity that we experience today are shaped by intentional historical events, policies, and practices. And that is what we do with students during orientation, the beginning of the year. We give them all these scenarios. And the big problem, the challenge with diversity, inclusion, and cultural competency was that we were just providing data, right? Like the students come in and see, oh, there is this disparity or inequities between this and this, in this disease and that disease, and then that is all they get. However, when we present a scenario and where there's an encounter, a clinical encounter, somebody comes and the physician orders some intervention, go and do some exercise in your neighborhood, right? For example, and we tell them that, oh, unfortunately, the person doesn't have a sidewalk, right? I mean, that's the end of the story usually. Then we ask them, why is that? Why does the person not have? We had, like a great article about segregation in Norfolk just the other day, correct? Neighborhood segregation. So those are policies and practices that shape it. We need to understand what those, underlying inequities are in order to be able to understand them. So that's what the humility is brought in here, to understand those power dynamics.
A couple of you have touched upon this, and I'd like to explore this a little bit more as we deal with this COVID-19 pandemic. A lot of African Americans have become much more aware of what we call the social determinants of health, and they are increasingly becoming more aware of incidents like the Tuskegee experiment and the Henrietta Lacks situation. And a number of them will use those historical events as reasons for them not to get vaccinated against COVID. I am curious initially of what your thoughts are on the COVID-19 vaccination. I've actually had my first shot. I'm waiting until March 5th for my second dose. But your thoughts on the efficacy of the COVID-19 vaccine, and I know there are 3 different types. And what would you say to an African American that uses those historical events as a reason not to become vaccinated? And if you don't want to chime in.
Well, I got my first shot 2 or 3 weeks, 3 weeks ago. Well, 3 weeks ago, because I'm getting my second shot on Friday, and I'm an African American, and I don't have any contraindications to the shot. So I am pressing upon everyone I know to please get the vaccination. We've talked about Tuskegee and experimentation and not trusting your healthcare provider. So this is where I had to say African-American healthcare providers should really take a lead and say that, look, I got my vaccination. It's essential that you get your vaccination. This is not Tuskegee. This is not the experimentation. And it's offered to everyone, and you should include yourself in that program.
Anyone else care to chime in on that?
Within our organization, I think all of the physicians received the vaccination when it became available. There was one who was a contraindication, and even of the nursing staff, there was a much lower incidence of people getting vaccinated. And it's just, I think you lead by example. I am from the school of you model behavior, and so you just model the behavior. And my nurse was hesitant, and I've seen the devastations of COVID-19 and what it can do. I've lost patients and family members, and so I look at it. Whatever you're thinking that the vaccination will do, I can assure them that the COVID-19 for the masses is much worse. So to me, it's just common sense. So I tend not to go into the Tuskegee experiment. That was many, many years ago, understanding history, but this is now, and you have a choice, and I model the behavior of getting the vaccine.
Yeah, a lot of people do. Just unfortunately, they will use that as an excuse not to be vaccinated. Natalie, you were going to say something.
Yeah, the one thing that I would throw out there too is a lot of people have reached out to me to ask me about it, to say, is this something they should do or shouldn't do, and so on. And I've really encouraged people, first of all, to do their own research and to make sure that they are going and getting the information so they can feel comfortable about making this decision for themselves. And I think the thing when people say, well, what's different now than, let's say, what happened when Tuskegee happened? I think it's that there are Black people who have been involved in the process of developing the vaccines. And that is something that is different than what we saw before, right? So this idea around power in the making of this vaccine is a really critical component of this. And I think to elevate those scientists and those people who have been involved in bringing the vaccine to market, who are Black and people of color, is critically important in terms of building some of the trust so that people will feel more comfortable and confident about taking it. That, and I think what both Dr. Mercer and Dr. Fleming said about Black docs leading by example.
Yeah, and the only thing I want to add is that and the NMA has actually really created a statement on this and practically a campaign to get more people involved in the vaccination, which I think meaningful.
Okay, I want to flip the page a bit here. We talked about some folks that will use these historical things as a reason not to, and they will cite those as mistrust of medical institutions. But one of the reasons, one of the most effective ways to address and tackle the health disparities that impact African Americans is to increase awareness of those disparities. This is not at all making any reference to historical things, but just a lack of information. All of you are working in professional environments. What value do you place on community participation and disseminating the word of being much more aware of these disparities? And I know that you do a bit of that, Natalie, with when you go around, speaking around the country. But what value do you guys place on active community participation in terms of helping you to deliver those messages?
Well, I'll say that for the work that I've done in communities throughout the country with regard to public health for the past 20, 25 years, I think I've always thought, first of all, it's not that community should have a seat at the table, but community is the table. And that is a very different way to work on the public's health, right? And so in that, there is an opportunity for community to determine its own destiny. And if that is the way that we respect, value, and engage with communities, they then become ambassadors for the work that's necessary to move the vaccine out into communities and populations to get the right information, not the disinformation, into the hands and into the minds of people, right? And so we have to leverage the community institutions, certainly that African Americans have historically depended upon. We've got to actually also leverage new and emerging technology. And so that is a critical piece of this entire thing. I look at what Black churches have done in the midst of the pandemic to move to these online platforms to be able to reach their congregants, right? And so that becomes another mechanism to be able to move information out. So as much as there is, and people say, well, how do we combat disinformation? And I want to be clear, disinformation versus misinformation.
Yes.
Disinformation is with intent, right? That's the one that we really need to worry about because it has strategy behind it. And so if we want to counteract that in a way that Black people really recognize that they can help to determine their own health destiny at a community level, we have to then disseminate information that can counteract those wrong messages. And that's part of what's been missing. That's part of what public health always struggles with, because, you know, those of us who work in public health always say, when public health is working, nobody knows that it's there. But when public health doesn't work, everybody knows that it's there, because when there's the E. coli outbreak, everybody starts talking about the health department, right? But nobody talks about the health department when there's no outbreak. We've got to change that so that people can begin to recognize that they play a role in this production of the public's health, regardless of what it is that they do, right? And then give them a place to plug in to determining that collective health destiny. So I think there are a lot of opportunities for community, not only to engage, but to lead what happens with their health.
Absolutely. Any other comments?
I have to agree with Ms. Burke. But I really think it's essential. And I really think the community involvement is really the platform for leading. The good news, and I have to say, hate to say this, but this is not new to the African American community, to the Black doctors. We worked in our churches, and I'm a grassroots person. You know, and I really think it's essential to work in our churches, to work in our health centers, in our doctors' offices, within the community, to just push this whole thing forward. We've talked about health inequities forever. But now the little bit of differences, and it could be a maximum difference if we know how to run with this thing, is that the corporations, you know, are all engaged. You know, United Way, they got $10 million from Mackenzie Scott. And so they're having conversations within the community, 150 conversations in the next few months about what the community needs. Centera Healthcare has these different kind of grants, and they're related to health inequities, and wants to develop a center related to health inequities. And so this is new. Us Black doctors have been fighting this for forever. And so now we have corporations with dollars that are buying in. And so I think we really need to run with this while we have this at our hands.
Terrance, you have some comments in the chat if you want to kind of
Yes, I picked up on one of those. We're talking about vaccinations and immunizations and so forth. One of the, a lot of people refuse to get the flu shot because of a lot of concerns about the flu shot. Some people choose not to have their kids immunized against childhood diseases. Some thought that they might cause autism and so forth, specifically the measles vaccine. Have there been long-term studies of of any potential side effects of vaccinations? I see you smiling, Dr. Fleming.
Well, you know, you have to define long-term. So who asked the question, I'd say define long-term. The vaccine was just approved within the last 3 months. And the expectation that this time last year, we really weren't dealing with COVID-19. We didn't know what it was. The schools didn't close until March. And so we don't have that information with regard to long-term because it is so new. It's like a clinical trials that I do. So it takes time to understand things, and you have to do the due diligence and do the trials to understand if something is effective. But the nice thing about the COVID-19 vaccination trials were they weren't rushed despite the political pressures to rush them through. What you see is an example when you put resources, i.e. money, towards a situation, you're going to get solutions. So Dr. Mercer's point, when a large organization puts corporate dollars behind this is important, you're setting the agenda and you're letting people know within the organization, health equity is now important to this organization. Dr. Mercer and doctors like her for years were doing these type of things. They were on, their practices are in the community. Now the only difference is there's now corporate dollars to say this is important and we need to kind of work with groups that are out there. And churches, if you want to get something accomplished in the Black community, traditionally and probably in the future, you got to go to your church. So when I first started my practice 15 years ago, I was spending my Saturdays and Sundays trying to build my reputation, good, bad, or indifferent, and I was in the community from that perspective. And people talk. So my practice is in Hampton, my practice is in Norfolk, and when people talk one way or the other about Dr. Fleming, they can ask a friend or family member, they know about me, and my reputation, what it is. It's not always positive. I can be direct. I can tell you things you don't want to hear, but my reputation is my reputation.
Yeah, we are about to run out of time there. We're actually at the time, but in as much as we were delayed a few minutes, even before we had to snap you with the video, if you guys will indulge me for just a couple more minutes. I think that question actually may have not necessarily been exclusively related to COVID vaccine, but the historical perspective some people have had about vaccinations. And there has been someone is participating, and Ms. Hare, I don't know if you're waving your hand, and if you're waving your hand, if you were applauding. I think that's applause, and if that is in fact the case, thank you so very much. And I see, thank you, she did say applause. Let's see, I thought I saw another question here. There is someone that is very interested in working in the evenings to help interview locally that want to continue getting the word out. What I think I would like to do now, and by the way, we're going to add that video to the recording of this session. What I would like to do now is go ahead on and close and give each of you an opportunity to say any final words that you might have. Let's start in reverse order. Dr. Fleming, any final words that any concluding question you have?
You guys should be listening to my co-presenters. They provided excellent information, and thank you for having me.
And I will be seeing you, sir, soon. I have an appointment to see you. And Dr. Mercer.
Just thank you for including me in this panel discussion. I look forward to discussing this further with in other entities and other venues. And I would encourage people to become active in whatever kind of conversations they can have now as far as community and community leaders, and get vaccinated.
How about it? Mr. Gemeda.
I also want to thank them for including me in this wonderful conversation with wonderful people. And I just want to say that it has been, some terrible few years that we've had, but on the other side, what has come out of it is hopefully ways for us to critically see some things that have been around for a while, and for us to engage in meaningful ways to change the experiences of people. So thank you for having me, and look forward to working with you.
And Natalie, AKA Dr. Burke.
I told y'all that's my mama. So what I would say is, what an interesting moment, this convergence of a pandemic, George Floyd being killed on video, the emergence and mainstreaming of BLM, even though BLM existed for years prior to this. 2020 really serves as this point of intersection of all of these things to create an opportunity for us to shift the national narrative around Black health, because people started to talk about the potential of valuing Black life. And so it's up to us to take this moment and to exploit the heck out of it, to make sure that when those opportunities emerge for us to be able to talk about these issues, that we are speaking in a way that we bring a unified voice, easily understood by communities and populations who are most deeply impacted and affected by what's happening, and that we truly invest in changes in policies and practices that really serve as barriers to people's health and reframe them in a way that are about producing good health. Black bodies are not broken. And I'm tired, in a sense, of having conversations and hearing people talk about Black bodies, Black culture, and Black people as though we are broken. We are not broken. Systems, institutions are broken, but we are not broken. So our work has to be about fixing those systems and institutions so that every single one of us has an opportunity to be healthy. And part of the way that we need to make that case is this: if I am not healthy, you can't be healthy either, because health is a collective thing. It is not an individual thing. We've got to get people to begin to understand that. So I'll stop there because I'm about to get on a soapbox, because Black people are not broken.
You know, you could get on a soapbox for me anytime, and that's why I invited you as well as everyone else. You guys have been an excellent panel. We've gotten some great feedback in the chat. Again, I want to thank you all so very much. For those of you that are watching, this is going to be recorded, and it's going to be placed on the Tidewater Community College YouTube channel, and it's going to be edited in such a way that the trailer for the film will be included, and it's going to be a nice presentation. Guys, again, thank you all so very much. Ms. Phillips, Alicia, I'm going to turn it back over to you.
All right, thank you all for being here with us today on this afternoon with this critical conversation, and thank you to the audience who have joined us. All we have to say is stay curious, stay engaged, stay motivated, and be well, and have a great evening.
All right, guys, take care. Again, thank you so very much.
Thanks, everybody.
Bye-bye.